Good evening, everyone. I'll be presenting the case Restoring a Lost Globe Post-Trauma. So just a brief about traumatic globe dislocation. The globe is suspended within the orbit with suspensory ligament of Lockwood, the lateral and medial check ligaments, and it is supported by a bed of orbital fat. So post-traumatic large fractures can lead to the prolapse of the orbital tissue as well as the extraocular muscles into the adjacent sinuses, and in severe injuries with sufficient force to disrupt the soft tissue protection can cause the globe to herniate or subluxate. So we encountered the case of a 55-year-old male who presented to our emergency department with history of loss of vision in the left eye after fall from a ladder. The history dates back to one day where the patient lost vision in the left eye when he fell from a ladder while he was doing household work. No other remarkable ocular or systemic history was present. There was no loss of consciousness or ENT bleed present. On presentation, the visual acuity in the right eye was 20/30 with the unremarkable anterior and posterior segment examination. However, in the left eye, the patient was PL negative. We had no view of the pupil. The adenexa showed a repaired upper lid laceration with interrupted 6-0 sutures. The socket appeared empty and the UM could not be assessed. The globe was not visible and we had no view of the fundus. So summarizing the case was a 55-year-old male with a history of blunt trauma to the left eye with loss of vision with sutured laceration with the left globe absent. So we suspected either a traumatic enophthalmos or an auto-enucleated globe. So we went ahead with investigations. A CT scan was done that gave us the finding of left eye enophthalmos with heterogeneous area of signal attenuation with fat stranding and hemorrhagic foci. The intraocular and the proximal part of the left optic nerve could not be visualized and the rest of the optic nerve was within normal limit. Our management was to start with IV levofloxacin 500 milligram for 5 days and IV methylpred was started and globe exploration with a team approach of an ophthalmologist and oral and maxillofacial surgeon was planned. So we went ahead with an orbital decompression with FES. A transconjunctival incision was given. Preseptal and subperiosteal dissection of the entire orbital floor was present and the contents were lifted and a titanium mesh was placed and it was fixed with the help of screws. So on the post-op day 1 of repair, the patient was still PL negative. The pupil was fixed mid-dilated with restriction in all gazes. The sutures were intact and the anterior segment showed a subconch hemorrhage with a sphincter tear, iris pigments on the lens, and the fundus showed a picture of a Persher retinopathy, which can be seen in this image. So this was 6 weeks post the repair. This is a composite picture. The patient was still PL negative, but there was lack of any enophthalmos. The ocular movements of the patient was there with mild limitation in the left upgaze and the left levo-rotation. The fundus finding post 6 weeks was surprising. The blood trauma had now led to the occlusion of the terminal macular arterioles and it presented with a pseudo-Persher retinopathy. There was disc pallor, attenuated retinal arteries and paramacular retinal arterial occlusion was present. So Persher has been reported after indirect trauma such as head trauma, long bone fractures. Ours is a case of pseudo-Persher retinopathy following a globe dislocation. Once we reviewed the literature, we found that only 26 such cases of traumatic globe disluxation into the sinuses were formed, and unfortunately, 9 of them only regained complete or partial vision. Our present case fits into 2023, where blunt trauma led to this injury. The presenting and the final visual acuity was no PL, and we had given 1 gram of steroids for a period of 5 days. So none of the cases had any evidence of a direct trauma to the optic nerve and the retinal findings. So we hypothesized that the sudden shock waves, they converged on the posterior pole. There was disruption of the endothelium due to the sudden deformation. Platelet aggregation led to thrombus formation and arterial thrombosis and occlusion facilitated by local vasospasm occurred as a response to trauma. So our carry home messages, we are reporting a case of a rare traumatic globe dislocation in which the patient has regained cosmesis but no vision after doing the globe repositioning. CRA could be associated with blunt trauma and globe dislocation when the prognosis is visual. As we postgraduates are the first line of our emergency management, it is a rare scenario where prompt initial evaluation as well as interdepartmental collaboration in our case resulted in a good cosmetic outcome. Thank you.
Thank you, Dr. Arushi. How big was that orbital fracture?
Ma'am, he had a Leaford fracture 3 and the medial and the inferior wall of the orbit was fractured.
Okay, so what are the indications of immediate fracture repair? Like usually we wait for 2 weeks. So what is the indication of immediate repair?
Ma'am, in our case, the orbital...
I know about your case. What are the other indications?
Ma'am, if orbital nerve is involved, then decompression is urgently required. in case of enophthalmos, if the globe is not seen, if we are suspecting that the globe has subluxated into the sinuses, then urgent repair is required.
Okay, and also if there is an entrapment of inferior rectus with associated vasovagal signs like bradycardia, then it's an urgency and you need to repair it as early as possible. Being an oculoplastic surgeon, I just have one thing. I think instead of taking help from the maxillofacial people, we should try to repair the orbital fractures with the help of oculoplastic surgeons. Thank you. Any more questions?
Nobody could hear you. You have to speak louder.
Ma'am, we are yet to publish this case.
Yeah, please, you can send it to IGO case reports.
Thank
Nice
you.
documentation also.
Thank you, sir.